Hi, my name is Katherine and I'm a freshman at the University of Michigan. This summer, through the Office of Civic Education Initiatives, I once again had the opportunity to work with my mentor, Dr. Aaron Berber, in endocrine surgery through the Science Internship Program. The title of my research project this year was The Learning Curve Associated with Robotic Adrenal Removal. Through the years, many technological advancements have occurred regarding the surgical procedure choice for removing adrenal tumors. Traditionally, removal of the adrenal glands was performed as an open procedure. Although effective, this option leaves the patient with an increased risk of complications. Through surgical advancements, the Da Vinci robotic system has recently arisen as a leading technological asset in minimally invasive surgery. As with all newer procedures, a learning curve is required for robotic adrenalectomies. The question then becomes, what is a learning curve? In 1885, German psychologist Hermann Ebbinghaus experimented and pioneered the world's first learning curve. Ebbinghaus discovered that the curve is a graphic presentation of the effects of a specific method of teaching, in this particular case, a robotic adrenalectomy. The two adrenal glands are located, one on top of each kidney, which can be found on the lower back beneath the rib cage. They are triangular in shape, normally the size of a thumb, golden in color, and secrete many hormones throughout the body, including the hormone responsible for the flight or fight response. Now that we know the basics of the adrenal gland, we must discover why removal is necessary. The most common reason endocrine surgeons are required to remove the glands are because they are secreting excess hormones throughout the body, most likely from a benign tumor residing within the gland. However, in some cases, the tumors are malignant or cancerous and can grow to become quite large. At this stage, it is likewise becomes imperative to remove the glands for the health of the patient. The hypothesis for this study is the robotic approach to adrenal surgery has a certain learning curve, and operative efficiency can be achieved over time. Since there are two ways to perform a robotic adrenalectomy, we furthermore hypothesized that since the technique is more demanding, we anticipate that the learning curve with the posterior approach will be more prominent. For the first step of the study, 65 patients, all who underwent a robotic adrenalectomy by the endocrine surgery staff at the Cleveland Clinic, were separated into two separate groups. 32 patients who underwent a posterior operation, and the remaining 33 patients who underwent a lateral operation. Next, 12 demographic, clinical, and operative parameters were used to calculate the learning curve. These include gender, age, body mass index, or BMI, the diagnostics, the type of tumor, tumor size, length of hospital stay, estimated blood loss, or EBL, and finally, the operative time parameters. When a patient undergoes a robotic procedure, the time in the operating room is broken down as follows. The total operative time is defined as the skin-to-skin time, or when the surgeon makes the first incision until the closing. The docking time is the time required to affix the robotic arms to the ports on the patient. Console time is from identification of the tumor until complete excision of said tumor is completed robotically. Exposure is simply defined from the initial incision to visual identification of the tumor. And finally, the irrigation and suction time occurs after the excision of the tumor, when hemostasis of the surrounding tissue occurs. This figure shows the patient demographics of the two study groups and the initial total population. All values in the table are expressed as the mean plus or minus the standard error of the mean. This table shows no significant differences within the separated populations in gender, age, BMI, tumor size, and tumor types. Figure 2 contains the operative characteristics of the two groups. Like Figure 1, the data is expressed as the mean plus or minus the standard error of the mean, and there are no significant differences. This first line graph displays the learning curve of the lateral robotic adrenalectomy. Each color below the graph corresponds to the matching line and operative time above. The x-axis is defined as the chronologic case dates, starting from the first robotic adrenal surgery at the Cleveland Clinic in 2007, with the most recent in late July of 2011, and the y-axis represents time in minutes. Seeing as there is no point on which the graph where all of the operative times level off, there is not a significant learning curve associated with the lateral approach. This second graph shows the learning curve of the posterior approach to robotic adrenal surgery. The x and y-axis remain the same, as well as chronologic case order and total time. However, with this curve, after the 13th case, a distinct leveling off can be seen on the graph, proving a learning curve is required when using this specific approach. In conclusion, our results do validate our second hypothesis. Based upon these results, our study suggests that the lateral approach is a much more straightforward procedure and is significantly similar to that of its laparoscopic counterpart. In this case, the learning curve is less obvious. However, like our hypothesis suggests, the learning curve becomes prominent in the posterior approach. Based upon the evaluated trend, the learning curve for the posterior approach is, as said before, approximately 13 cases. Throughout the entire operative series, a significant improvement is clearly seen over time, despite a few peaks. It is highly recommended for any experienced laparoscopic surgeons contemplating the robotic approach for an adrenalectomy to first begin with the lateral approach and later transition into the posterior, as we have proven this technique has a steeper learning curve. I would like to thank my mentor of 2 years, Dr. Aaron Berber, for his continuous support and guidance throughout the summer, as well as his influence in my decision to pursue medicine. Additionally, I would like to thank the entire endocrine surgery staff who adopted me as their own. Thank you also to the Office of Civic Education Initiatives for this opportunity. And finally, I would like to thank my parents and my brothers who have always been there for me and have been the pillars of my support system throughout my education. Thank you.